Good morning, everyone.
Good morning.
For those of you online, it's Dave Hurl, Chair of Education for the Vinayak Foundation, and I want to welcome you all to the 2024-2025 season, the next school year. So great to have you all here. We have a terrific lineup for you this year. Thanks to the help of Maya, our manager, and John, our AV tech specialist, and of course, the wonderful committee that backs us all up. Throughout the year, please continue to feed us with your ideas. We always appreciate hearing from you in terms of new speakers and ideas that maybe aren't represented that we need to hear about. So that's always terrific and very helpful, but I can assure you that this year we have a great program before you. This morning, I'd like to also thank Johnson & Johnson and Connexa, our sponsors for today. So please say hello to them and thank them for being a part of our weekly program. Also, in the future, I wanted to mention that we will be going back to featuring a research trial at the beginning of each grand round that the foundation is participating in that really shows you kind of the depth and breadth of the clinical programs and the research that is brought before the foundation. Today, our speaker hardly needs any introduction. Dr. Bapat is well known nationally and internationally, and we are very fortunate to have him part of the foundation and the Minneapolis Heart Institute. He's going to be speaking with us today about when transcatheter techniques go awry. So without further ado, Dr. Bapat.
Thank you, David. That's one way to become popular with cardiology colleagues. Let's get this going. So these are my disclosures. I work with most of the heart valve companies. It has always been my passion to dive and understand into what I use every day so that I can give hopefully useful feedback and help in product development. I trained in India, worked in England, did a fellowship in Canada, and now I'm in the United States. And what I've seen over the last 30 years is the heart valve therapy continues to grow, continues to swing in different directions. And the reason for that is the disease pattern is changing. We also have patient demands. Nobody wants a more invasive therapy. And more importantly, life expectancy is increasing as well. So all these things really reflect on what we do today, and probably what we'll be doing in 10 years may be different. I love to show this slide every time about Dwight Harkins. This was 10 Commandments of Ideal Valve. This was in 1966, before I was born. And one of the things was, do we have a valve substitute which can last lifelong for a patient? Now, of course, we know that that really doesn't exist because we may have something like a mechanical valve, but at the same time, they need anticoagulation, they can be noisy. So the generation change happened at that time in, I would say in 1980s, to move towards biological valves, which have gone through many iterations. Now, if we're doing a biological valve, why not do it through transcatheter? And then we have seen many of these designs come and go. And eventually, I think what it landed was in 2002, Dr. Alan Cribier, who passed away recently, did the first case. We saw in Europe a massive explosion of TAVR devices when I was there. By 2014, we had nearly 9 to 10 devices already CE marked. Now, various advances, mainly in imaging, valve design, and more importantly, delivery system, we got TAVR approved in 2019 all across the world, I would say, in all risk patients. That means we can technically treat anyone. And in fact, in the United States, it's pretty regulated, but elsewhere, you can even treat a 20-year-old with a TAVR if they can pay for it. Indication expansion was natural. As you can see, we have devices approved for aortic regurg. We are doing trials on asymptomatic AS, moderate AS, as MHIF, and Paul is leading one of the trials. Therapy expansion has been massive. This started out of need, but valve in valve, valve in ring, valve in MAC is now well established in our fabric. And other areas such as transcatheter mitral, tricuspid, a lot of innovative technology in heart failure is on the go. So what it means by that is we'll be doing new procedures in complex patients as it started with TAVR. And that, of course, needs a lot of attention and care. So what is the role of surgery? And John Kirkland, who was one of the pioneers in heart surgery, said that it's always the second best. He also said that it is operating someone who has no place else to go. Now, probably this was a good viewpoint in 1970, but now with the Heart Team 1, 2, and probably 3.0, things are slightly different. So the way I look at it is surgery is a stakeholder in all these three. We cannot detach ourselves from this because it's all patient-centered. We need to be participating in pre-procedure planning, case selection, during the procedure to support the cases, and post-procedure, of course, in monitoring. And the topic of today is when we do surgery, if the transcatheter treatment fails or doesn't deliver as expected. Now, this is the algorithm on which I think transcatheter treatments work: function and fixation. If you get good function, that's great, but you need good fixation. Otherwise, the valve is not stable or leads to leakage. Same way, you cannot compromise on function. You can have good fixation, but it doesn't work properly. So what do we have? I generally divide this into TAVR failures at the start and then maybe later. So failure is not really a good word. Now, with today, the TAVR failures have become very uncommon on the table. We have very good imaging. We can select the valve type, valve choice, valve size. Delivery systems have become really good. As you know, that there are nearly 1,000 centers in US doing TAVR very successfully with a failure rate of less than 0.5%. So there are things where tertiary centers tend to push the envelope. And this is that gray zone where we think patients high risk, anatomy is not really favorable, but can we still do a TAVR to avoid open surgery? And in these cases, sometimes, whether we like it or not, failures do happen, and the surgeons and the team has to jump in. Now, these are my very early cases. This is coronary obstruction on the left side. This is a valve embolization, which I caused. My heart nearly stopped at that point. And then annular rupture. Rizwan Atia, who is one of my colleagues here, was my trainee at that time, new video camera, and it happened. So we fortunately recorded it. Now, all these things needed a lot of lateral thinking at that point. I'm talking of before 2010, 2011, on how we manage this, because we're not savvy. We didn't have CT scans. We didn't have sophisticated echoes to understand sizing and the device. To be honest, there were only two sizes with two devices. Secondly, the life expectancy is increasing. As I said, it's approved in all the patients now. So like the surgical valves, we are going to see a lot of patients with TAVR who are going to come back with failure. Now, this is the life expectancy in Western world. In Japan and Korea, it's actually 10 years more. So if we start doing these cases in 65, 70-year-olds, mandatory bioprosthetic valves are going to fail and we are going to need surgery. So surgery for acute is really life-threatening complications or sometimes simple. But for chronic, now we have to plan. And more patients we are expecting in next 10 years to come back for that. Now, this is Mick Jagger. So he landed in New York. I'm sure many people have read about this. He was 70 years old that time, and he decided to have TAVR. Now, he was in Cornell, where it's one of the very bullish and strong surgical team. However, he wanted to do this, and this was 7 days after his TAVR. Now, that's great, but maybe by 76 or 78, he might land up on surgical table. Now, why? Is because we know that TAVR degeneration happens. This is a paper led by Miho and Paul on TAVR deformation. We know that there are risks of something called as HORT, uneven expansion, and that eventually feeds into degeneration. And to be honest, all biological valves are going to degenerate. Let's remember the Dwight Harkin's 10 commandments. So in these patients, we have only two options. Now, this is the hardest part. We have selected a less invasive approach to start with. And now when the patient's older, we are trying to tell them that now, by the way, you're going to need a more invasive surgery. And this is why at present this field is evolving in terms of what's not just right for the patient, what the patient perceives is right for them, but what is actually right for the patient in terms of longevity. So what we don't want to do is put in another TAVR or send them for surgery and change their life expectancy curve. And this is where a lot of effort has been put in. Let's take an example from our own practice. This is a TAVR at the age of 75 in 2017 with SAPIEN 323. In 2022, patient presents with symptomatic stenosis again. What do we do in this patient? Should this patient have surgery or should they have TAVR? Now, this looks very simple in expert hands. If I just show you the fluoro, this is one TAVR inside another TAVR. These are two different cases. What it doesn't show you is these have been carefully planned, carefully selected, and carefully executed procedures. So my feeling is at least 30% may not be even suitable for this. Additional 30% should not be done in centers with low volume. And maybe there are many patients where intra-procedure planning is going to be needed for good execution. We have also published a lot of guidelines in terms of how to assess and how to do this. But let's take those 30% where we can't do this and why. Patients with infective endocarditis, these valves need to come out and then need to be replaced. Patients may develop other issues like mitral stenosis, mitral regurg. Patients may have coronary disease, aortic aneurysms. More importantly, in the yellow zone is when we have analyzed it and redo TAVR is not feasible. That means if we do it, we may get life-threatening problems or suboptimal result. The last thing you want to do is do another procedure and then get the patient back for a more complex procedure 2 years later. And very importantly, the last indication, we did a live case at New York Valves in terms of what is known as patient prosthesis mismatch, or the TAVR has degenerated for reasons we still don't know. And these things can happen. If a valve doesn't last for what is expected 7 to 8 years, the last thing you want to do now is put a smaller valve inside, which is 100% going to last. So why there is no confidence in surgery, in TAVR explant? Very early result, this is by one of our friends in Michigan. You can see that the early results of TAVR explant showed a mortality in double figures, like 20%. But these patients were older, sicker, a lot of patients with endocarditis. Current publications show that this is trending downwards, and a lot of effort has been taken by us now for 7 years now in educating ourselves in terms of how to reduce the mortality and morbidity of these procedures. So the first important thing, 90% of surgeons are generally not aware of what transcatheter valves are, their designs are, how to analyze them. So very important that the first teaching we do is start understanding frame design. For example, a simple frame design is more complicated than dual frame design. Dual frame design tends to interact in a very different way with surrounding anatomy. A tall frame is different than a short frame, and these are small subtleties which come into play when you do operation. If you apply one technique to the other, maybe you will end up with a complication. We use imaging very heavily, and this has fortunately been part of my journey, at least from 2008. CT imaging is really critical. We start looking at, we see everything on the table, but we now start looking at scans to apply our learnings and then learn more. For example, here in this particular case, I would see that I cannot give cardioplegia directly into the coronary. So I need to have a strategy of doing what is called as retrograde cardioplegia to protect the heart. If I don't do this properly, I can explant the valve, but maybe the post-op ICU stays longer and the outcome is poor. It's a very simple thing, but a lot of surgeons probably don't use this at present. We can also plan valve size as is done in this institution. We can plan more complex procedures like root enlargement. And I remember a time when I was called in many years ago. I was the youngest surgeon in St. Thomas's. And one of my senior most surgeons who trained me had never done root enlargement. So he anticipated it and he made sure that I was there to help him during that procedure. So we can now predict it on CT scans very well. Now, when we expand the diver, we really need to pay attention to all these things. And as I said, tall valves are different than short valves because of their design and their interaction. And these are some of the things we keep in mind. Can we damage the aorta during this procedure, or mitral valve, or conduction tissue? We don't want to convert a relatively simple procedure into a very complex procedure. Most surgeons are impatient. I'm one of them. So when I did this procedures early, I was rushing for no reason. And slowly just slowing things down, giving 10 to 15 minutes for TAVR explant, have improved my own results. This is one of our cases from Columbia University. CT is used regularly for planning. We plan everything on CT to reduce the impact of the procedure. Here, the aorta is being opened. You can see the valve which is degenerated in this patient. This is one of my senior residents doing the case, and he was impatient as well. However, you can see that slowly peeling off the stent frame by right instruments and not rushing into it allows you to separate the valve easily. What we have seen now in our experience and among 5 friends in this country, any valve which is there for more than 5 years tend to be stuck worse than those before 5. Here is being separated from the aortic valve. This is where injuries to the mitral valve and everything can happen. And this is where on the CT, we can already predict where the lower portion of the valve is. Once the valve is out, as you can see, then if you have not damaged anything, this becomes a straightforward aortic valve replacement. Now, we have learned a lot. A lot of these valves are made of nitinol. So we know that nitinol you can squeeze and make it a bit softer using ice slush, which is commonly used in open heart surgery, which is now used. This allows the valve to become softer and allows us, easier dissection. Again, a simple 2-minute trick, but again, this can really decrease the complexity of the operation. We have also started using different techniques, such as the same principle is these tall devices are essentially squeezed into a pencil-sized delivery system. So why not use the same technique to help us explant it? So what we do now is we put different purse strings or sutures, and we snare it into a small tube. Now this reduces, as you can see very nicely, compared to the first case, here you can see everything underneath the valve. And this really allows the easier explantation of these devices. So all such tricks and techniques, again, we are trying to disseminate throughout the world so that these patients are going to not necessarily come here or to tertiary centers. They're just going to go to their local centers. I call this crocodile roll after visiting Australia. Don't ask me why. Not why I didn't go to Australia. But with sapien valve, which is balloon expandable, you can't do those other 2 techniques I showed you. This is a balloon expandable valve. It doesn't shrink down. So it has to be crushed inside or cut. So Dr. Vince Gaudiani, who is one of my mentors, came up with a very nice test, and he calls it mustache roll. But essentially cutting the frame in the middle and then rolling the valve over the instruments, as you can see here very nicely. That tends to wrap the valve around the instruments to reduce its size, and that leads to less problem in exciting this valve. Now, funny enough, although this is a short device, I at least think that this sometimes is harder to explant because it tends to go much bigger in the LVOT. Now, indication expansion has happened, as I mentioned earlier. We are doing valve in valve, valve in ring, valve in max. Why we are doing it? Because it's easy. In 2010, this is one of my cases in St. Thomas's, a 29-year-old, a third time re-op. We did this procedure in less than 1 hour that time. He went home, was playing soccer with his family, our kids in 1 month. So most patients would like to do this, or us to do it. But we also know that in all the patients, we may not get optimal result. That means what I mean by this is, if this is a 75-year-old, by doing this, we may not prolong the longevity of that combination to 85. Maybe they will come back before 80. And so we, again, our center has been really in front of this. We have published a lot on this deformation. As you can see that these things do affect what is called as durability. This is the case example. This is the patient 64. She rightly had, lung except the pathology. She underwent surgery, but unfortunately, the valve inserted was much smaller. It was a 19 trifecta. Not surprisingly, the patient came back in 14 months. We looked at what was in, this patient was from Georgia. And so they decided at that point that she has COPD, probably do a valve in valve, which was, I would say, not a wrong decision. But you can see the true ID, that blue mark is 17 millimeters, and our smallest valve is 23. So you can see already that it is going to be 4 to more millimeters under expanded. And this patient underwent TAVR, and then 9 months later, Paul and me got a call. We airlifted the patient here. We analyzed it, and we realized that this is probably not going to last at all, even if we balloon it. So this patient underwent a very successful open heart surgery, and we did a root enlargement, which probably should have been done before, and then had a much larger valve and hopefully longer term benefit. So valve in valve is very good option if it's done in the right patient with right combination. But we can't blindside ourselves by thinking, let's just do this and it's going to last forever. This is more interesting. And this is one of the early cases of valve in valve, mitral. Now, mitral valves are luckily bigger. So we don't have that problem. That's what we thought. But you can see here that this can become very good screensaver if you want it. It's hypnotizing, right? Not at that point, because high five was going on in 1 minute and then things changed. And of course, this patient needed surgery. Now, why did that happen? We were trying to explore that, and then many other things happened. And you can see here, this is a case from Helsinki done by my best friend. I was telling him use a 29, but he used 26. And 3 months later, this valve moved up. And this put a lot of, we realized there were some other cases as well. In Riyadh, I did a case with that team, similar picture in 6 days. So we realized that this happens because the closing pressures on the mitrals are very high. And we can't just apply the same thing as aortic valve in valve. And that led to this conical deployment philosophy, which is applied everywhere in the mitral trials now. But at the same time, you make it bigger. Now you have this deformation issue. And I sometimes wish CT scan never existed because we never would look into these things. So now the issue is, it's a rock and hard place, because if you undersize it a bit, you will get good function, but there's a risk of embolization where you need that wedge, but then that leads to malfunction or early degeneration. So we have a philosophy of optimizing these on the table, which we have been doing successfully. And I think in future, there has to be some guidance in terms of right oversize. And we don't know what that is at present. This is again one of my amazing contributions to the field. Patient has a mitral valve. She had some psychiatric issues. This patient had undergone a Sapien XT some years ago. It lasted 4 years. She came back surgically. I could do the operation, but I think post-op was going to be difficult. So we decided we are now going to put a Sapien 3, 23 size. That lasted 9 months. And so we had to finally do the surgery, a bit complicated surgery for a variety of reasons. But you can see how that explanted valve looks like. That's never going to last long. So we have learned a lot that just promising patients will do one procedure, then second, now I hear in meetings even third. I always say that this may be possible, but the longevity will not be there, because there is only so much space and so much constraint in what we can do. Now, if we think that the aortic valve, TAVR, and everything is complicated, welcome to surgical world where mitral valve in the ring is really complicated. And they always say that you're not a famous mitral surgeon unless a ring is named after you. So we have got 24 famous surgeons with 24 different rings. And you can see the size, shapes, and also the material which goes into making this. Uh, I have taken 14 years to try and simplify this. It's still very hard. I do get constant questions every month. I've got this ring, should I do it or not? We have got a great resource in terms of the apps, but still people want to make sure they're doing the right thing. And the reason for that is you can see the number of rings. Each ring has many sizes, and each size has different dimensions. So again, basic philosophy, fixation and function. We want to maintain circular shape, but we also want a good fixation. And in this, it's really hard because what we cannot control is the design of the ring. It is there, what's there. We have come up with guidance. This was a paper actually I wrote in 2013, and then I put it on my shelf because I thought it was way ahead of time. Now we are going to publish it in 2024 of five. I still think it is ahead of time because this is a really complicated subject because surgical products and transcatheter products, ironically manufactured by the same manufacturer, are not aligned. And that has been now the battle for 5 years for me. Why not they align their products to make our life easy rather than we spending 2 decades of our life in simplifying it. And that's, I think, going to be the next frontier for at least Medtronic and Edwards Lifesciences. Essentially, dividing these rings into 4 parts is critical. Again, you can see anchor and circularity, function and fixation. Some rings which are both green are great. I mean, you can achieve really good result. But some ring where either both are red or one is red, you may not get good results. So as I said before for TAVR, some patients, this is still acceptable. These are the patients where surgery is not possible. But if surgery is possible, probably not a good idea to do it. So there is this classification of, green, yellow, and red in terms of when to call a friend and when actually not to do the case at all. So going to show you another, again, a very complicated case. This is a 76-year-old female patient, past history of MRTR, had a surgery at that point. This is a band which is there in the mitral. There's a lot of regurgitation. For whatever reason, that center decided this patient's too high risk for surgery, and then we should do a valve in the ring. And this was what was done. So the first valve went in, ironically, it kind of moved up. And the reason is, this is in the gray zone ring. It's an incomplete band. Actually means, honestly, we will not do this case here. But anyway, the valve moved. So they put a second valve now. They just couldn't manipulate the valve. There's a lot of stent-to-stent interaction. They were using a rail through the aorta, which sometimes can be counterproductive. The second valve landed similar. They tried to move it down with a balloon. That didn't happen. At that time, the surgeons were called in because already 2 valves have gone in. It's not good. And rightly so, they decided what all of us would decide is put a third valve in. So now the third valve is going in. And third valve, as you see, landed slightly lower, but a lot of leakage still. This was not acceptable. And fortunately, one of my trainees who was attending the Francesco was called in, and he said, I'll happily operate the patient, but the procedure has already been from morning to late afternoon, the general anesthesia. So what they did rightly is shifted the patient to ICU, stabilized her, they operated next day, and fortunately, she had a good outcome. And they actually tried the fourth valve as well. So the reason to show this is surgery is needed. And in our center, for example, we are integral part of this. So I don't think we will probably cross the first stage, but even if we cross that for whatever reason, we'll make probably a different choice at second stage. As I said, that's not enough. In some cases, we get good result, but that doesn't last long. This is a Physio 2 ring, which is actually quite good for valve in ring. But in this patient, for example, you can see the valve is pretty unexpanded. And in the explanted valve, although, as I said, you have to crush it, the leaflets look a bit calcified and one of the leaflet is frozen. So we need to follow these patients very carefully and pick them up before they deteriorate further to operate them at right time as well. Now, mitral annular calcification is the next frontier, as we thought at that point, because as you can see here, the calcification provides you anatomical rig. And these patients are quite high risk in many terms. So this is one of our early cases. As you can see, this was the Lotus device by Boston that time. We did the case. This patient actually lived for 3.5 years, and she was 89 at that point. So you can see she had a SAPIEN XT. So good results can be achieved in carefully selected patients. However, as I say, I'm showing you all my contributions to this field. This is the case of TAVR in MAC. We were pretty experienced that time. I was in Columbia University, slightly higher area, but we had good successes in these patients. So we decided, again, patient high risk, morbidly obese, on oxygen, etc. So we did the first SAPIEN with some extra volume. It looked good, but not that good. It was moving a bit. So we decided to put a second valve just to stabilize this and expand this further. And as you can see, as the second valve goes in, it looked again relatively stable. You can also see it's hard to see things because patient is obese as well. It's very difficult to, and the calcification is what we fondly call as popcorn calcification. It's not very solid calcification. Anyway, so we did that, and as expected, or not expected, the valve embolized. Now there were two valves, nobody wanted to operate this patient at that point. So we had seen a case by Bill O'Neill many years ago. And so we used the ASD closure device to trap the valve in the septum. And then again, we sent the patient home. Now, luckily, this patient had 2 TAVR devices stretching this mitral valve. Her breathing got better. And then 3 months later, she came without oxygen. And then I operated this patient. And this was a very interesting operation. Again, careful planning, careful team, and really good ICU support is critical for a good outcome. Here, explanting, as you can see, that ASD closure device with a trapped SAPIEN 2 valves was interesting. And I really say interesting as a Midwest interesting. And it led to, I had to excise the atrial septum completely. This is a patient I really wanted to do minimum. I wanted to do quick mitral valve and get out. This led to a slightly longer procedure because we had to reconstruct the atrial septum because there was no other way to bring this out. And this patient, fortunately, as you can see, had a very nice, mitral valve replacement. Annular rupture can happen as well in these patients. And again, we try our best to have that fixation function algorithm. But there are some things we just can't control, and these can suddenly become very complicated procedures. Mitral clip, just moving slightly a different topic. TEER or mitral clip has become, established procedure, and in our center, especially, we are one of the expert centers in the world, and this is our algorithm, I would say, in terms of how we shift patients to which side. And I think the green and yellows mainly, not applicable to this center, but many centers, or sometimes to us as well, is we can't control what the quality of tissue is, for example. It is what it is. We can't control sometimes how well we can see the valve. And in yellow zones, especially, there are patients where I'll say, Paul, let's just do the clip. I'm going to replace the valve anyway. And you'll be surprised that in 80% of patients, we don't need surgery. So again, these two groups of patients is always a win-win scenario if you try the clip. Green, I'm not speaking about, but the yellow. Now, this is a patient, one of our patients actually. Again, patient had multiple pathologies, mitral, aortic, 88, 89-year-old. Can you do surgery? Sure. Do you really want to do it? No. So what we decided was we'll do the clips first. Let's see. Paul was pretty hesitant because of Barlow's multiple prolapses, but we attempted it. But more importantly, when we felt that this has not given us that optimal result, so that we can take the next step, which was a TAVR, we would rather bring this patient back, optimize the patient with our heart failure colleagues, and then do, open heart surgery. So this is one of our patients we did for TCT live, again, doing mitral valve replacement and then tricuspid repair. But more importantly, we used a transaortic TAVR to cut down that extra 60 minutes of bypass time. And this patient, sure, stayed longer in the hospital, but eventually is doing better because of this particular procedure. So again, you can't call it failure in a way, but this is appropriate failure, I would say. Why this clips fail sometimes is this is just an example. There are multiple rupture cords. This is a patient again, just to show you why these things can happen. But there are sometimes very tricky things, and this is another of our case here. Pretty high risk case for surgery. We decided to do the clip. At that point, the result initially was felt to be good. But here I'm just showing the medial orifice. You can see the two clips have actually done a great job. I mean, the clip portion is working very well. But when I inject first time some saline, which we do on the table, you will see that there is a lot of leak. And this leak is because what is called as 3D clefts or anatomical clefts. But when I separate the leaflets out, you see that actually there's a lot of mitral valve there. And these are very complex anatomies. And these complex anatomies, of course, there's no way, even if we try to get some result in maybe fit patients or intermediate risk patients, surgery is the best option then. So we removed the clips and then did a mitral valve surgery. And at the same time, we also went ahead and repaired the tricuspid valve. So again, appropriately chosen in that yellow, 70, 80%, I would say we win. But in those 30, 20%, we decide surgery is actually the next step. And we don't delay surgery, then becomes very critical. This is just to show you the tricuspid annuloplasty, and then a very good result with that. You'll see that in a second. Advantage of surgery, of course, then is we can fix the tricuspid as well at the same time. TMVR is the new frontier, not new anymore. I've been involved in it since 2013. Tricuspid valve, again, we are doing more and more cases. There are multiple of these devices, more complex than TAVR, and trust me, all of them have had, some surgical bailout at some point. That's the nature of this therapy. This therapy is complicated, delivery is complicated, so there's always going to be surgical participation, and I think that backup is very, very important. Lastly, quite a cool case which Dr. Beckman did here in our center. As we know that Watchman and Amulet devices are used now, and the idea of this device is that it closes the LA appendage so patients can come off warfarin. Unfortunately, this patient, for whatever reason, developed this atrial mass. And as you can see here, in this patient, appropriately, this thrombus was removed. And you will see that the main question was, can we remove this Watchman device? The Watchman device was sealing the appendage beautifully, but you will see that in the second, what was the nidus for the thrombus. And you can see here, it's being carefully dissected of the Watchman device. And you can see the mitral valve at around 9 o'clock. And it was that, portion where it's attached that was causing the thrombus. If we had tried to explant it, it would have become maybe unnecessary complicated procedure. So what he did was he used a mitral valve sizer to shape a patch of pericardium. And essentially, we sutured this patch on top of that device so that we reduced again a complex procedure into a very simple procedure. And we know from cardiac surgical use that using pericardium, it gets endothelialized very beautifully. As you can see here, that this is probably never going to cause thrombus again. We checked the mitral valve was good. And hopefully this patient has now a good benefit in terms of what she essentially had before. So my summary for all this is technology has limitations. We cannot say surgery is good or TAVR is good or transcatheter is good. Actually, everything has limitations, and hence proper patient selection is very important. There are multiple registries floated by surgeons and cardiologists in understanding this second step, which is surgery. As you can see, we are going to actually, this is going to explode. It's already exploded, but more so. We have so many products for so many therapies. You can see that, surgery and cardiology and imaging is going to be integral part of this. This not, surgery is not going to be a bystander in any of this. Again, when I was young, I used to go to a cafe and I used to see, they would ask me tea or coffee, and now you get so many options, even in our Sky Cafe. So choice can lead to confusion, especially for simple people like me. It can also introduce bias, very important. It's really critical, and it can happen to people. People have gone and ordered a cappuccino and have been given latte and haven't realized that it is actually not cappuccino. But I think this is what our approach is, right? Individualized approach. That's very important. You may have a lot of choices, but five fingers are not same. You have a lot of patience. How do we fit this into step one, step two? That's our challenge, actually. And this is what is important for the younger generation here, is from can we do it to should we do it? This is very critical. Can we do it? Of course, you can do surgery, you can do transcatheter, but should we be doing this not just the first time, now in fact is the second time? Robust follow-up, which luckily our system has because it's a very close-knit system. Rediscussing the patients, don't feel ashamed of it. If there's a bad result, bring it back so we can take the next step. Educating surgeons and educating cardiologists into these cross specialties is really critical, but patient education is important. A lot of patients come and they think, I don't surgery, wow, And I keep telling them that if your transcatheter treatment fails, revisit it as a new pathology. Like, don't necessarily think that second treatment is naturally going to be transcatheter. It gives them a focus of understanding that science is progressing in everywhere. And our ICU here is just amazing. We are currently engaged in this beautiful color-coded diagrams on the best guess how this lifetime management is going to look like. But nobody has a clue, to be honest, because this is based on flawed evidence to start with. We have never used these 1, 2, 3 algorithms ever. This is just personal experiences. Sequencing, this is another term commonly used. And this is why science and research is really important. So what efforts are being made? As you know that our MHIF app portfolio is increasing. This is not just towards transcatheter treatment, but also, as you can see, we have an app called Valve PPM, where we encourage surgeons to look at the CT scan, the dimensions, choose the right size valve, so that that patient from Georgia situation doesn't happen. This allows you to have good case selection, robust discussions, and second case planning. This app is just not, algorithmic, but this has features such as we are going to start now case of the month. We also have video resources to teach surgeons in how to explant this TAVR so that they don't have to attend conferences and webinars. It's there on their phone when they need it. We are interacting with the industry all the time. My first visit to Minneapolis was visiting St. Jude, trying to convince their board that they need to make their valve visible. It's taken 12 years. I had to move to Minneapolis, actually. So you can see the same valve, but now it can be seen better. So once it can be seen better, we can do a transcatheter valve better, less complications in terms of embolization. Valves such as Inspiris, which are expandable, have been developed with clinician partnership. We are engaging with new transcatheter valves so that they last longer. We have an amazing research team here, and you can see that they not only engage in developing science, but also presenting. Some of them have gone back, and they're going to lead this effort all over the world. We have an absolutely amazing team, surgical and cardiology team. And you can see that I'm very proud to say we're the only surgical team in the country, or probably the world, where all surgeons are engaged in transcatheter. This is very unique. Even in Colombia, we had two surgeons engaging 24/7, but the others were a bit peripheral. But here, we are very, very unique. We engage in a proper way, and I hope this continues because understanding imaging, understanding transcatheter is really critical. Valve Center, again, we are involved in demonstrating every year. We get a request. Can you show something which is hybrid or something which is surgical? And every year we come up with something new, novel, and useful, more importantly. And this is, again, I think the important thing is patient-centric. A healthy debate, mutual respect is really important. And this is what is finally, this is my fourth winter, or probably the fifth now. I remember showing this slide after my first winter, and thank you very much for this opportunity to share some of the so-called not transcatheter failures necessarily, but why surgery and techniques are evolving and why they're robust in giving us better outcome. Thank you.
Thank you for that talk. That was a fantastic coverage of a lot of different topics. As we're talking about TAVRs and starting to move those TAVRs into the moderate space, what are some of the considerations that you see coming up in the future with these, healthier, less symptomatic patients who are receiving TAVRs?
So I think the main question is where that expanding indication in terms of moderate AS. We use a definition for aortic stenosis, which is from 1960s or 70s. And I think the patients so-called moderate AS we look at are probably physiologically more severe. I think the same thing will apply to them. My biggest worry in these patients is, for the trials at least, is the small annuli patients. I sometimes wish that those were excluded from the trial because moderate AS by definition is 1 to 1.4. And then smaller annuli, we don't get the EOA increase or increment to that point. That would technically be my only concern at present in terms of how those patients do. But I think the trials are very appropriate in exploring that indication because these are not patients who are otherwise healthy with extremely good ventricles with moderate AS. These are patients who have some other problems as well. But essentially, the role of surgery will be more.
Outstanding review, and thanks so much for teaching us through these years how we can be also helpful. I would like you to please reflect on the dogma that has been around about, surgery is not an option for patients with mitral calcification, and where can we as imagers also help you surgeons prepare patient selection for that.
Yeah, so mitral annular calcification has always been a technical challenge as well, and now we know that it's a physiological challenge as well. A lot of these patients have, say, diastolic LV failure, etc. But what we have used in this center, and Rizwan has recently published that as well, is how we can use CT scan in terms of understanding surgical difficulty as well. When I say surgical difficulty, there are only two issues. One is, can I first take sutures in the calcium? Because that's the fear. And the second thing is, can I put an appropriately sized valve? If these two can be simplified or predicted, I think we will then choose the right patients for surgery because a lot of these patients are surgically not high risk. Surgically, they are low or intermediate risk. Now, the advantage of doing surgery, if you can simplify and do it, is that biological valves or mechanical valves, can be implanted. And even if it's biological, they generally don't need anticoagulation for that. So I think in MAC, definitely, I showed you some of the cases. We had great hope of that. We started that in London in a big way. When I came to New York, I learned they were doing SAPIEN in mitral, like it was very high volume. I sat with Isaac and we really cut it down to when it's mandatory. And to be fair, in last 7.5 years in United States, I've used SAPIEN open in a MAC maybe once. So it has not been, needed. But when it's needed, it's really appropriate. Absolutely.
Sure. Fantastic talk. You mentioned your considerations of mitral valve and ring and when green and green in terms of fixation function. is that influencing your choice of ring presently, thinking down the line? Or is that conversation you're having with companies about you're not putting yourself in a place for success down the line?
Absolutely. So a lot of things have changed now, Steve. So for FMR, as you know, we used to do what is called as an undersized ring, which is rigid. And the common theme was, to use the 28 size ring, which accommodates my thumb. That practice has gone down now. And in United States, especially, I think if patient needs surgery for FMR, for something else, generally valves get replaced with a biological valve. So that's the first thing. The second thing is some of the rings have gone out of market now completely. The ring called Geoform, IMR, which were not only rigid, they were very asymmetric. Edwards has phased them out. Interestingly, the bands have remained now. The reason is robotic and less invasive. Band is easy to implant. But on the other side, when you use a band, you don't shrink the valve down. And that's actually become better for future tier. So you can actually retain the, so to speak, normal geometry and not shrink it down as we do with full rings. So some effort, Medtronic, as I heard recently, is also going to cut down their portfolio for that reason. There is some effort going into how can you make these rigid rings circular later. We are working with Edwards on one of the concepts for that. So there is slow adaptation, but not necessarily, this topic is not heavily discussed in surgical meetings. Let me put it that way. Not yet.
Vinny, is a great talk.
Yeah.
I particularly was enamored with your slide on choice and how choice leads to confusion. And I mean, it's a common thing when patients come, they're confused. And the options, they're either confused or they're really focused on one, one outcome versus the other. But thank you for being here and being a partner, because having those options for the patients is so important, covering everything.
And I think what really resonates here is that we discuss the patients in the Valve Center. I think that meeting of Thursday, it was supposed to be 1 hour. It usually goes for 2 now. Is because we discuss it. Patients actually like that. Patients like that surgeons understand and engage in transcatheter. That resonates. So I always tell them that one of the team members will call you later, what's appropriate, and discuss with you. And this is at least what I feel is they feel better if they need surgery. I've never been to a patient who's very few patients, but other than that, you say, you're going to have surgery and there's a smile on the face. No, it's uncommon, right? Generally, they come and you say, you need surgery. They're already worried about it. But I think engaging into them, the conversation that we are looking at imaging together, we have experts looking at everything. Anticipating problems is very important. Lowering mortality, which is their biggest fear, stroke and mortality really, is giving them an option. And they do see us today in what we do. One of our patients quoted his daughter is to work for Medtronic. She works for Medtronic. And he just retired from Medtronic. That he looks at the literature, he saw our surgical sizing paper. And he liked that. And he asked me, and I said, now we are looking at, can we reduce pacemaker rates using membranous septum height in surgery? Patients feel, okay, we are engaged. We are not surgeons who are just focused on opening chest and replacing the valve, putting sutures, but we're looking at this imaging before we are applying it. Secondly, I must say that the unsung heroes in our practice is our ICU. Our ICU is just phenomenal. Our intensive care, we do 52% patients are inpatients. Our results are so good only because we have excellent ICU care here, and that's Alex and his team. So taking these patients on after discussion, getting heart failure involved, Peter's team, I think has been very critical in the success as well. Great. Thank you.